Hello everyone, my name is Ajay Sharma, one of the Paediatric Gastroenterologists based in Perth. I'm just going to briefly talk about eosinophilic esophagitis, and I have divided my talk briefly in terms of talking about the basics. I've added some case-based discussions from the real cases. The patients are de-identified, and we'll talk about how we manage and what's the future holds. So to set the scene, we have this little bub who's a 14-month-old LD. It's a child who has been having ongoing reflux symptoms in form of vomiting, back arching, sleep disruption, and struggle to feed. Has been tried a few things in the past, including reflux medication, and briefly tried food elimination with limited success, and the child started having choking whilst eating solids, hence was referred to us. This child had a good weight gain and had known allergies to egg. So when we decided to go ahead with the endoscopy, we found that the esophagus was quite inflamed, which is a picture on the right as compared to a healthy normal esophagus, which you can see on the left hand side of the slide. So there was significant inflammation, and the biopsy confirmed this child having eosinophilic esophagitis, also called as EoE. So what is EoE, or what is eosinophilic esophagitis? So here, in a simple terms, what it means is a condition where your food pipe or the esophagus becomes inflamed and swollen, making it very hard to swallow food. And what's the culprit here? The culprit are the immune cells, which are called eosinophils, which usually help in fighting against the parasites or some inflammation. So these cells, they start to build up in the esophageal wall, and they start attacking the food pipe by mistake. How common it is? It is becoming very common. In general terms, nowadays 1 in 2,000 individuals are generally showing signs and symptoms of EoE. What causes EoE? So we have few various predisposing factors, starting from the genes. Sometimes you're born with a tendency for your immune system to overreact. Then there are environmental triggers, which are the commonest culprit, and out of that is usually the food antigens, like your common food, dairy, soy, egg, nuts, seafood, can be a culprit. Environmental allergies like pollens and dust mite can also be a trigger for EoE. And this creates an overreaction in the esophagus, which gets flooded with eosinophilic cells, started to cause damage in the esophagus. So these antigens coming from other food or environmental allergies starts disrupting the lining of the mucosa of the esophagus, and hence the immune system becomes overactive, creating inflammation. This is just a slide to show that even in Australia and New Zealand, we are seeing more numbers of EoE as compared to many years back. This is data which we published from capital cities in Australia and New Zealand, and before 2011 till 2011 to 15, the data clearly shows that the bar is increasing in every capital city. Unfortunately, we couldn't capture the data from the regional centers. Who gets more EoE? Well, it's 3 times more common in males, but can present in any age group, right from infants to toddlers, children, teens, and adults. One interesting thing is that 50% it's more common in individuals who have allergic tendency. For example, asthma, eczema, allergies to food, environmental allergies, they are more prone for EoE. How do they present? So the symptoms in pediatrics we've divided into 3 main categories. So the infants and young children can present with feeding refusal. They might take a long time to feed. They might have some preferences for soft food, ongoing unexplained vomiting, slow weight gain, or regurgitation. That can be due to eosinophilic esophagitis. The school-going children usually presents with tummy pain or chest pain, trouble swallowing food, heartburns. And the teenagers can present with that frequent choking, which is called as dysphagia, or food getting impacted in the food pipe, apart from chest pain and heartburns. This is called impact behavioral scale, whereby you can ask some questions to the families to see whether there might be a troublesome swallowing happening, especially for a child who has been having excessive sauces with solid foods. Just try to sort of imbibe those fluids, or they're modifying their food. For example, they're deconstructing food to swallow, prolonged meal times, avoiding hard textural food, or the child is chewing excessively before swallowing. So these can be a clue that there might be some inflammation going on the food pipe. Common associated conditions in pediatrics with patients with EoE, you can get almost 50 to 60% of children who have allergic rhinitis or asthma. Other food allergies, which can be associated with eosinophilic-esophagitis. There are certain non-allergic conditions which may be associated with eosinophilic-esophagitis. For example, celiac disease or any other autoimmune condition, operated fistula in the tracheoesophageal area can be increased risk factor for EoE. How does the endoscopy gives us a clue? So these are the various pictures of eosinophilic-esophagitis in various grades, starting from mild to severe, which can give us information that the esophagus is abnormal. What happens when you don't treat? When you don't treat, you may end up with complications. For example, it may form stricture or a hard, narrowed esophagus. You may have frequent pill impaction or a very narrow esophagus whereby food keeps getting stuck all the time. How you diagnose? So, of course, you have to see a doctor, see a gastroenterologist who may perform a procedure called an endoscopy, whereby the thin camera goes into the food pipe, and the doctor will look into the appearances as we saw in the picture and take tiny tissue samples, which are called biopsies, to send it to a pathologist. And if you see eosinophils under the microscope, more than 15, which is the number which we use, then it could be due to eosinophilic-esophagitis. How do we treat? So there are various approaches here. You can do some dietary adjustments which are empiric. So removing triggers food like milk, wheat, eggs can reduce inflammation and improve the symptoms. Then medications, you can use other swallowed steroids. You have to swallow, and it can coat the esophagus and calm down the immune cells. There are certain injections called biologics, which are the game changer, and the commonest one is dupilumab, which hopefully will be soon licensed in this country for eosinophilic-esophagitis management. It's now approved in US as a treatment for eosinophilic-esophagitis. It works by blocking the allergic signals that causes EoE, and if the esophagitis is severe and has already formed stricture, then of course you have to do stretching from inside by dilating the esophagus through the endoscopy. So common triggers, we talked about milk and dairy products, wheat and gluten, eggs, nuts and seafood, or soy products. Generally other foods like fresh foods, vegetables, fruits, rice and berries, they are considered to be safe food. When you do a food elimination therapy, you have to see a dietitian, your pediatrician or a general practitioner or a gastroenterologist, because it has to be done in a more protocolized way, and the success rate can vary depending upon what are the triggers and whether you do a step down or step up approach. For example, one food elimination give you success almost 30 to 40%. If you do a 6 food elimination diet, the success rate increases up to 40 to 70%. Then there are specific formulas like elemental formula in infants and young kids, which we can use, which has got almost 90% success rate. So I'm just going to go through a couple of examples here. Again, this is another case. This is a 5-year-old who was referred for fussy eating habits, had trouble with food, and was diagnosed with sensory feeding issues, but on history had other allergic conditions, including eczema. But there was no obvious vomiting or dysphagia. That means struggle with swallowing as such. He was just considered to be a fussy eater. This is the first endoscopy which confirmed a significant esophagitis. All these white exudates are allergic cells creating a shock in the food pipe. And after treatment of 6 food elimination, the esophagus started looking healthy. And once we started putting one food back in the diet, the wheat was the culprit here, which showed a recurrence of EoE. So this child is doing very well on one food elimination and is in complete remission and is eating well and is not considered to be fussy anymore. On the other hand, what happens if the dietary adjustments doesn't work, or parents do not prefer diet therapy for various reasons because it's already too restricted diet? And this case highlights this scenario whereby this child had eosinophilic esophagitis diagnosed on endoscopy, and initially the 6 food elimination was tried but was unsuccessful. Hence the decision was made to start this child on swallowed steroids, and it worked brilliant. The esophagus became healthy, and that was the maintenance strategy for this child. There's another case here for a 10-year-old I've mentioned here with the background of multiple allergies, was already diagnosed with EoE and was doing well, but for various reasons the treatments were stopped, and the child was referred to us for heartburns, chest pain and trouble swallowing. Had a significant inflammation in the esophagus with narrowing of the esophagus. So we treated a bit more aggressively, and you can see that the esophagus became healthy and the esophagitis improved. But what happened was this child, because he was doing well, again the treatment for certain reasons was stopped. Almost for 2 years the child was not on treatment and started to choke again. So the message here is that if you don't have any maintenance treatment, there is no gain, and unfortunately the EoE will recur majority of times, and this is the same child who without treatment again had a florid EoE with some stricture. So when it comes to management, you need to have a multidisciplinary team approach in collaboration in diagnosing and managing eosinophilic esophagitis. Ideally you should have your GP, a dietitian, a feeding specialist, allergist, a gastroenterologist, and sometimes you need a psychologist, because this can be a significant mental health challenge for family and patients as well. EoE does contribute significantly in the burden in the healthcare, not only in the utilization of healthcare resources, but also the cost of the care. It can be expensive because some patients can have frequent visits to ED. They may need repeat endoscopies. It might start affecting their quality of life, and they might have other comorbid conditions, and hence it's important to have the team to look after a patient with EoE and the family. So to summarize, the take-home message here is that for EoE, we need to have high index of suspicion. We do see in children or adults who have more commonly other allergic conditions, including eczema and asthma. The aim should be to reverse the inflammation, and a maintenance strategy is a must, as we saw in the case report that no maintenance is no gain. And if you stop the treatment, and EoE may recur in majority of times, the management needs a multidisciplinary team, and the biologics or the dupilumab injections usually will be the future in general. That's where most of the area of research is happening. So finally, you're not alone. EoE can be challenging, but with the right diagnosis and a personalized treatment plan, it is very manageable. If you have any questions or concerns regarding someone whom you know or your child, speak to your doctor, your GP, or a gastroenterologist, or an allergist if you think your child may have an EoE, and then the treatment can be considered. Thanks for your attention. Thank you.